Welcome, welcome everybody. We are so excited to have you guys here for our inaugural series. This is a series focused for family members and individuals, and of course, clinicians are always welcome. Again, my name is Dr. Elizabeth Mackinville. I'm the director of the OCD Institute of Texas, and we recently, just this month, launched our first ever what we're calling learning series. And the series is called In Session, and we're going to have a couple webinars every month. Each month we'll have one webinar designed for clinicians and a webinar designed for family members and individuals, which is the one you're here today joining. We are also going to have two other times per month to meet. One is going to be an open clinical consultation, and one is going to be what we call an AMA. So Ask Me Anything, where clinicians will come and you'll have a chance to just ask questions live. And this will really be designated more for individuals and families. I'm so excited to be joined by two of our clinicians from here at OCD Institute of Texas, Victoria Lane and Dr. Callie Werner. Both have extensive experience treating OCD and working with families, engaging in both space therapy and, of course, OCD-specific interventions and education for family members and individuals. Today's webinar is going to be all about understanding anxiety in kids, how to support and recognize them. And so, of course, we'll spend some time talking about the basics, going through education, and then we'll hop into Q&A that will be moderated both with pre-submitted questions and then, of course, also with questions that you guys submit live. So please make sure you put questions on today's webinar live in our chat so that we can answer them as we go. But we're excited, and welcome so much, Victoria and Callie. We're so excited to have you both here, and I'll let them take over.
To get us started, I'd like to discuss the difference between generalized anxiety and OCD. I think oftentimes we get misconceptions with trying to determine if something is all OCD or something is all general worry or general anxiety. And so really, we want to be able to differentiate the two because we treat them a little bit differently. Generalized anxiety and worry often tied to real life concerns. They're content switches, and so it might be that someone is a kiddo's worried about their grades or their assignments, and they're worried about mom and dad not being able to kiss them goodnight, or they're worried about just overthinking and over-preparing for a lot of different things, and it feels like we can't really grasp one concept of what they're struggling with. Whereas OCD, the individual, the kiddo, is often really tied into a very specific worry. Contamination OCD, they're worried about their hands getting germs and spreading those germs, or with harm intrusive thoughts, they're worried about harming their loved one, or they're worried about their loved one coming into harm's way. Oftentimes, maybe that needing parents to tell them goodnight multiple times to ensure that they're going to be okay. The compulsions are involved in the OCD symptoms as well, and I've got to do this compulsion in order to feel better. I've got to make sure that everything is perfectly aligned in order to prevent something bad from happening. Whereas again, with generalized anxiety, it's this constant worry that something could happen and we really can't catch the worry, is the way that I would describe it.
Yeah, no, I love that. And I think one of the big things that's super important to note is that there's some sort of perceived threat in all of this, right? And an individual's response to that perceived threat can be really anything to alleviate their anxiety, anything to reduce that worry. And now we're going to talk a little bit about just what are some of the things that you might see at home, right? As a parent, as a caregiver. So just some common presentations. And one of the most important things is a lot of these symptoms can be normative behaviors that you see in your child growing up. But how do you really tell when it starts to really interfere with their daily life or interfere with the family's life as a whole? So some common presentations that we might see of whether it's anxiety or OCD at home is maybe some excessive reassurance seeking. This can look like so many different things, but really kind of the standard is your child might be coming up to you so many times a day with a lot of urgency, asking either the same question or very similar questions over and over and over again until they get that perfect answer that their anxiety is looking for. And our natural response, and we'll talk about that a little bit more later, is probably to answer that question, right? And to kind of keep moving forward. Some other common behaviors you might see is them having difficulty leaving the house. Now, this can be for so many different reasons. I think one of the ones we often see is just because anxiety can be so stressful and so heavy on the individual, that they would rather just stay home and not face the triggers that might bring about their anxiety. So they would rather like isolate and stay in their bedroom. You can also see it, we see a lot in like contamination OCD, like, well, I have to wash my hands 20 times before I can leave the house, so I'd rather just stay home. Or maybe like the other comment it says here, checking behaviors. Maybe they're checking the stove or checking the locks 20 million times. So, as you can imagine, anxiety and OCD can show up in so many different areas of your house. And this is not even close to an entire list of different ways, but we want to touch upon a couple of main things. And the reason I want to touch upon a few of these is because they can often be misconstrued, right? So, let's take fear of making a mistake, for example. So often we can easily go, oh, fear of making a mistake. They just don't want to mess up. They want to be perfect. But maybe there's like a deeper rooted fear there. Maybe that fear of making a mistake is because if they make a mistake on a homework assignment or a project that they're doing, they can feel like they're a bad person for it. So it's really important to really get to the core and understand what is driving it, right? Some behaviors that we see is avoidance. So whether that's avoidance of social situations, avoidance of going to school, right? Avoidance of spending time with family. We can also see some like irritability. We can see emotional dysregulation, right? We can see so many different things that maybe we could potentially see as normative, but what I want us to think about is if it's starting to interfere with your child's life, it's starting to interfere with your child's ability to function, do the things that they enjoy, but also starting to interfere with your family's life. Maybe you're changing up your routine or schedule. Maybe you're jumping in to try and save your child from feeling anxiety, right? These are all signs that maybe it's time to look into this a little bit more. And we talk about a lot over here is like, it's never really too early to seek therapy and to seek treatment for these things.
Yeah, and I would just add a question as Victoria was going over this list that I get from parents most often is that, well, should I just take my kid out of the thing that's making them anxious, right? I work with a lot of young performers and athletes, and they'll say, should they just stop the sport? It's not bringing them the joy that I thought it would. And our answer to that is that would be another form of avoidance, right? So we know that anxiety tends to latch onto the things that we care about most. And so if we're taking this kid out of theater or out of the sport or out of the thing that they were doing, more likely than not, the next thing that they start to get passionate about, that anxiety is just going to move right over into that area as well. And so it's so important for us to give that kiddo the skills, to give the family system the skills that they need so that the kid can learn to cope and they're making a values-based decision instead of an anxiety-driven decision.
Absolutely.
So let's go over what the anxiety cycle looks like, especially when we're plugging in something known as compulsions, right, that come from OCD. When an individual has an obsessive thought or a fear, they're often engaging in a ritual or compulsion to reduce the anxiety from that fear. And so the anxiety tends to go up. We'll use maybe a kiddo has a lot of perfectionistic tendencies around turning in an assignment at school. They feel like if they don't check this assignment 4 times, that they're going to really do poorly on the exam, and then maybe they catastrophize a little bit. Maybe there's some generalized anxiety tied to that of if I fail this exam, then I won't get into a good college, and then I won't be able to get enough income to live a successful, happy life. And so they start off by getting that anxiety, or that anxiety heightens. And then what they do is to relieve that anxiety, I'm going to check this assignment 4 times and they feel better, right? So that anxiety goes down. You can see that arrow dropping down on the screen there, which is all great, very temporarily until the next time they have an assignment and they have to check it 4 times again. And I can hear some of parents' thoughts on the other side of the screen saying, well, why is it so bad that they're checking their assignment 4 times? And the reality is, if there's a predisposition for anxiety, we know that when we give into compulsions, we're actually exacerbating the symptoms long term. So we are reinforcing to the brain that I have to do this compulsion in order to feel better. And our goal is actually to teach the brain that we don't need to rely on compulsions, that we don't have to keep engaging in these behaviors in order to get long-term relief. So that's where exposure therapy comes in. What we have for an exposure for this kid that's checking assignments 4 times might be you know what, we're going to lower that to 3 times. Maybe checking just once altogether would be way too intimidating or debilitating for that kid. Oftentimes, I like to use the example if someone comes in for outpatient therapy and I tell them to eliminate the first compulsion altogether, they might never come back to a session again, right? So we're starting off small. So maybe we just go to, can we tolerate the distress that comes from 3 times and really lean into our why? Why are we doing this? Well, I want to be able to be successful in assignments long term. If this is a kid that's in 3rd grade that's doing that, sometimes I'll give them some buy-in of, goodness, we're only going to have bigger workloads as school gets harder. Is it really sustainable for us to recheck all assignments that we're doing 4 times? Probably not, right? And so get their buy-in, get their values-based kind of reason why for doing the hard exposure work. And so they do it 3 times and maybe they feel that distress a little bit higher as you see on that cycle, the cycle going up even more. What we know if they lean into that value and if they continue to reduce compulsions is that anxiety can't stay that heightened forever and it will start to go down. So we keep repeating that exposure and maybe we drop it to 2 times and then 1 time. And what we see is that peak of anxiety gets lower and lower and lower as they've reduced that compulsion. Anything you'd add?
Yeah, no, I want us to talk a little bit about kind of parents' natural responses, right? And especially like when they're doing exposures, but also when they're not doing exposures,
Yeah.
right? And like when your kid is just very anxious and ultimately by no fault of parents, caregivers, loved ones, right? Our natural response is to jump in and just say like everything's gonna be okay, right? We don't have to worry about this. Like we can get through this together. And unfortunately, that doesn't work, right? Because what you're doing is you're responding to your child's anxiety. You're actually not responding to your child, right? So, a little bit as you see on the screen here, we have some sample statements that we can use. And this really comes from the SPACE program, as Liz was talking about earlier, around it's called Supportive Parenting for Anxious Child Emotions from Dr. Ellie Leibowitz out of Yale. And he comes up with this like kind of the sentence of support equals validation plus confidence. And what's so important here is the combination of both validation and confidence, right? So, and when we talk about validation, we're not necessarily talking about validation of your child's fears, that like these fears are really true and they're going to come true. We're talking about validation of your child's emotional experience, right? The discomfort, the distress they're going through. And then we're building confidence in their ability to move through that distress, right? To move through that discomfort. And what's so important here, right, is the combination of both. Because if we're validating our child without building confidence, or we're building confidence without validating, that actually doesn't look like that support that we're looking for in OCD and anxiety treatment, right? So some examples that you can see on the screen here are, I know this is hard for you, and I know you can handle this feeling. I'm so proud of you. Or it seems like this question is taking up a lot of space in your mind right now. Because I love you, I'm choosing not to answer. I know you can do this, right? These can be used whenever your child may come up to you and ask you for a reassurance question. Maybe your child is doing a hard exposure and you're attempting to build that confidence in them to move through that hard exposure. You really use these in any area aspect of life, right? But most often we use them when we are also slowly removing family accommodations, right? And if we want to talk a little bit about family accommodations.
Yeah, I would add to that, just like I had mentioned, our kiddos need a reason why for doing the hard work, right? Like I want to be successful in school, or I want to make sure that I can be more time efficient, time effective when I'm taking exams. Parents kind of need a reason why, because this is just as much of an exposure for them to utilize a validation plus confidence type of response, because they're not immediately rescuing their kid anymore to feel better in the moment. And that's hard, right? When we looked at that anxiety cycle, you're kind of having to ride that wave as well. And so we're reducing these accommodations while replacing them with these validation plus confidence equals support statements. And for accommodations, I think it's helpful for us to just identify very specific, like what might this look like? Well, the example that I used earlier of the kiddo that's checking their exam 4 times before they turn it in, or they're checking their homework assignment 4 times. Maybe what they start to do is ask mom and dad to get involved in that checking, or maybe they're willing to do the exposure of, I'm only going to 3 times, but they're asking mom if it's okay, right? Parents often say, well, what's the big deal? They're asking me if it's okay. And really that's kind of why we have to get back to what's the function of that behavior? Is that giving that kiddo that immediate relief that we're trying to no longer give them because it's just reinforcing the anxiety cycle? And if so, we need to help them learn to tolerate that distress a little bit longer. And so parents might be replacing that, you know what, I'm not going to answer by just saying, it's okay, everything's going to work out, with that validation plus confidence equals support type of statement. And that doesn't give that kid the immediate relief, but it does really teach them, wow, I've got some really amazing skills that I can utilize to get long-term freedom from this anxiety instead of staying stuck in the cycle. What's another example you'd add?
Absolutely. I love that. I think one of the first thing that pops up to my mind is a lot of kiddos will ask their parents questions before they go to bed, or will kind of say the same statement repetitively until they get a direct answer from their parents. And it's so normal for a parent to just respond to that question, right? And say, yeah, everything's going to be okay tonight. Like, go to bed. I'll see you tomorrow morning. Everything will be fine. Like, we'll go to school. Everything will be great. And really starting to teach the parent and the child, right, that they can both tolerate that anxiety. Because the reason parents and caregivers jump in is because we don't want to see our loved one in distress, right? That's the last thing that we want. So we're going to jump in. We're going to use these the supportive statements, and be able to really validate and build confidence in your child's ability to move through that distress. And I also love how you were talking about how this is an exposure for parents too.
Yeah.
Right? This is not just exposures for your children. This is exposures for the whole family.
Yeah, we're working on all building that distress tolerance. And sometimes I'll have parents even ask, but what if they're in distress? Like, what if they get to a state of panic or heightened anxiety? And we usually respond to that with, it's not dangerous. They can feel that heightened anxiety. The learning comes from how they cope with that on the other side of it, right? So we call that inhibitory learning. If the individual is getting the reassurance in order to reduce that anxiety, well, they're learning that I always need that reassurance. If instead your kiddo is saying, man, that was really hard and that did not feel good, but I woke up the next day and I went to class and I got my assignment back and I actually did okay without checking it 10 times, right? That inhibitory learning model is amazing for them because they see I really did tolerate this distress. Whereas when we're stuck in the OCD cycle, it's sending us the signal that we can't handle the distress. We can't tolerate it unless we do the compulsion, unless parents answer with this particular response. And that keeps us debilitated.
Yeah, no, absolutely. I love it. And I think this is where we want to open it to a live Q&A and really just kind of get into a discussion with you all. What questions do you have that you're kind of itching to have answers to? We also have some pre-submitted questions that we'll kind of go off of, but is there anything else you would add before we jump in?
No, I think we should dive right
Let's
in.
dive in.
Okay, we are so excited to hop into questions. And before we do, I think one thing I always struggle a lot with and always just want to talk about is the concept that I think it's really important to note that as clinicians, it's a lot easier to look from the outside and say what people should and shouldn't do and things they should fix versus in practice. And so can you talk about that a little bit of just what it's like when you as a clinician are like, yes, I can see that all these things need to change, but it's also like, I'm not the one at home there when the meltdown is happening, when the child is anxious, when they need to get them to eat dinner, we need homework done and to get to bed.
I would say oftentimes when I'm educating a parent, the first thing I say is, yeah, of course you respond in that way, right? Like, of course you're going to check that assignment for your kid one more time so that they can get to bed. That's natural human nature to be a mom to that kiddo. And even if it's my own child, I know that I would do the same thing initially because I want my kid to feel better and I'm the one that's in it with them. And so I just emphasize the importance of why it's so important to have that third party clinician guiding them through exposures and how to utilize a validation plus confidence statement or how to engage in a good exposure, because parents need to know that this is also getting them on the long-term route to success as well. I think it's so natural for anyone to respond to their child's distress by making the distress go away. Unfortunately, we also know that that just feeds the OCD cycle.
Totally. And I think that's my next question is how do parents like really start to differentiate when it is just like normal kid questions and anxiety versus like, or, you know, normal kid anxiety, because they all have it. Anxiety is normal to a degree, but like versus, oh, we're actually answering to anxiety or we're answering to OCD versus I'm answering to my child right now. How does a parent differentiate that?
Yeah, I love just starting with the word urgency, right? Like, what kind of sense of urgency are you sensing from your kid? Are you sensing, hey, I'm coming and asking a question that I actually don't know the answer to, and I want to gather more information? Or is your kid coming to you like, no, mom, I can't, I don't know what's going on. I don't know what to do here. Like, am I going to be okay? Right? That sense of urgency.
Yeah, and I think the thing I always say too is if it works, it's probably not anxiety or OCD in the sense that like if you just have to answer it one time and your child is like, oh, okay, like I remember when Olivia, my oldest, started having a little anxiety, like the first couple times that she would say, what time are you gonna wake me up in the morning? And I would say, oh, 7 o'clock, the same time I wake you up every day. And then no matter how many times I told her 7 o'clock, it was like she got more stuck and she actually got more dysregulated, so that's a really important sign and symptom. And that's the next question is how can parents know like when are these things that we can try to enforce some of the skills y'all are talking about on our own versus when we need to actually see a therapist and get that outside party brought in?
Yeah, I always kind of go back to, is it impacting your ability to function? We kind of look at three different areas, right? Home life, friend, social life, and school life. And if one of those areas is being negatively impacted, more likely than not, you probably need to bring in a sense of support from the outside source. Additionally, parents can often try utilizing a skill on their own, right? Just like you had mentioned, they might say, well, I tried to ask my kid if they would stop checking their homework 20 times before they would turn it in, and we just got nowhere with it, right? I also think there's no, we never could be preventative enough. So if we're getting that outside support, I never hear someone say, I wish I wouldn't have started therapy sooner, right? Because we know life gets harder. And regardless of how intense that problem is, as life gets more stressful, usually if we don't have the skills in place, symptoms tend to worsen with time. So by being preventative, you might be saving your kid and you from a lot of future stress.
Yeah, and then the other question I have before we've got some live that I want to hop into, but one thing I feel like sometimes parents think we're supposed to be miracle workers as clinicians, and so they'll say something like, "Okay, well, my kid," and I'll give an example actually this weekend, but this weekend I was with some friends and some of the kids were really like anxious and scared to go in the pool and to go down this water slide that was there in the pool. And some of the parents are like, Liz, what do we do? Like, and I'm like, I don't know. Like, I'm just right now. I'm right. And it wasn't that I don't know. It's like, I think it's important to note, and I would love for y'all to talk about just that, like, we know what works in the sense of like CBT and behavioral interventions and how to start to say, okay, what are you doing as a parent that's reinforcing anxiety? How do we do change behavior? But we're not going to also have the perfect answer every time. Sometimes it is trial and error. It is like, okay, let's remove this and let's add this in and see what happens. And does it move the needle or not? And so talk a little bit about that of like, what should parents' expectations be when they start therapy? And what is it like as they're trying these things you're teaching them at home in their environment? And does it always go right?
Yeah, no, absolutely. I like to start by just talking about the importance of data collection and just like you said, trial and error. Let's see what works. Let's see what doesn't work. Come back to the next session. Let's talk through it and make a plan moving forward. Right. And I think a lot of times the first couple of things you try probably won't work. Right. And they might backfire on you, or you might come up like your child might respond in so many different ways that you're like, well, how am I supposed to respond to this? Right. You're not going to have all of the answers going in right away.
Yeah, and I would also just add that it's so important for the parents to acknowledge the win or the difference in behavior that has happened so far. Yeah. Sometimes I'll have parents come in for maybe like session 2 or 3, and the kiddo did some really great homework, but the parent has already jumped to the next problem at hand.
And it's still there.
Right, right. And true behavioral work, we say it takes about 12 to 18 sessions before we really see that kid has built momentum around like session 5 or 6, we see that starting, but we have to get to that full mode of like freedom of them being able to utilize these skills on their own and have independence around it. And so if we're not acknowledging the wins, we're really making it harder on the kid too to stay motivated to do the hard exposure work.
100%. Well, I love this. Let's hop into live questions. And how do you differentiate between anxiety and OCD, and what screeners would you recommend specifically for kids, but also adults?
Yeah, no, absolutely. So one of the biggest differentiators between anxiety and OCD is anxiety is a lot about real life worries, right? So everyday worries, things that might be popping up, whether at school, at home. OCD is very specific to these unwanted, recurrent, intrusive thoughts. So those are the obsessions, and the compulsions are these repetitive behaviors that one does to try and relieve the anxiety that those intrusive thoughts cause, or try and get rid of that intrusive thought, right? So it's very specific themes, very, whether it's taboo, whether it is some contamination OCD, just very specific themes versus the general anxiety. area. One of my favorite screeners for OCD is the Children's Yale Brown Obsessive Compulsive Scale, so CyBox. And then I typically use the Generalized Anxiety Disorder 7 measure, GAD-7, for generalized anxiety.
Yeah, those are the two I would use as well.
And for adults, we would use the Y
The
box
Y-box, yeah.
instead of the CyBox. But yeah, great. And they're easy to use, 10 questions, they're short measures. So they're kind of nice because you can do it even in the first session and not feel like it's gonna take a long time. And so that leads to the next question. If you're suspecting OCD as a clinician, how do you talk to parents about that? Like, how do you help parents understand that and see that? What does that conversation look like?
Yeah, I mentioned earlier to those that are watching today that we would never want to change our lifestyle because of OCD, right? Or because of anxiety, because we know that it's treatable. We know that the individual can get better with effective evidence-based treatment. And so first, I would kind of work on assuring them that this is a diagnosable mental illness that's actually fairly common. You probably know someone else that's also struggling, or your kiddo probably knows someone else that's also struggling. And so on top of that, we know that treatment works. And so if the parent is thinking, well, should I just take them out of this extracurricular that's giving them so much stress, or should I just ask for additional accommodations because of the OCD? Oftentimes we would say, it's really good to have that therapist kind of advocate when there might be a temporary accommodation needed, but the goal is to get them back to full functioning, to get them back to a place where they can do everything that they would have been doing before the OCD symptoms onset. And they absolutely can do that.
100%. How, I guess, when you're seeing OCD or anxiety and maybe the parents aren't, or, I think one thing that's important for us to talk about is how often the parents are dealing with their own anxiety that they may not recognize. Like, how important is it that you have that clear conversation as clinicians, and also like just to set the groundwork for parents to understand that like it's actually pretty likely that we're also recommending anxiety work for the parents when a child has anxiety. And that makes sense because as a parent, like you're going to have to do things that make you feel really uncomfortable, right? We see this even with clinicians that start here and they're like, oh my gosh, I don't know how to do this. This is like so anxiety provoking. And we have to really coach them and train them on how to hold lines and why we don't give in to anxiety and why we don't reinforce it. But it also brings up our own anxiety that if it hasn't been treated, it can be problematic. And so how often are you recommending parents seek their own anxiety treatment, and how big of a role do they play in the therapy with their children?
Yeah, very often. And I really, the first couple of sessions, I like to include the parent in treatment as well, right? It's a lot of education and really helping both the child and the parent understand what is happening, what is going on, educating about family accommodations, how that might show up, and really starting to create a plan there.
Yeah, and I would say that in those first few sessions, it is so crucial for the parents to have the education as well, because 45 minutes once a week for this kid practicing exposure work or distress tolerance is not going to be enough. They have to be practicing this outside of sessions, and a lot of that time is in the home environment. And so if parents aren't in the know about what questions they should no longer be answering to that tend to feed the anxiety cycle, that kid is only going to get so far. So it's so important to incorporate the parent in the education piece, but also if the parent is having a really hard time managing their own distress by allowing their kid to experience distress, it's likely that they might need their own support system to just be able to process that in their own therapy sessions.
And talk for a minute about comorbidities. What are some of the common comorbidities of anxiety disorders and OCD, especially with kids and adolescents?
Yeah, it's more likely when someone has a diagnosis of OCD that they do tend to have a secondary diagnosis than not. And so we've talked a lot about generalized anxiety disorder today. Some obsessive-compulsive personality disorder, perfectionism can be a comorbidity. Skin picking or hair pulling are things that we look for, motor tics, verbal tics. Even just symptoms of panic disorder, panic diagnosis. What am I missing here?
Phobias.
Yeah,
some separation anxiety. That's a good one.
Yeah, all common. So anxiety-related disorders is what we usually say. OCD and anxiety-related disorders, that was just a list of some of the ones that we mentioned there. But when you do an intake with a really good provider, they should be screening for those related disorders as well, so that we're not missing anything and we're providing full appropriate treatment.
And of course, we always want to be on the lookout for depression, very often comorbid with anxiety and OCD disorders, especially when untreated. We'll see that depression emerge. What are some of your favorite books and workbooks for parents or even providers, but your favorite ones when we're thinking about kids and adolescents?
Yeah, my favorite one for parents is Breaking Free from Child Anxiety by Dr. Ellie Leibowitz out of Space, which is the space protocol.
Yeah, you stole mine. I also really like Giving Parents When a Family Member Has OCD by John Hirschfield. I just sent that to a parent today, actually. But even just freedom from OCD, like if a parent knows nothing about OCD and their kid is experiencing some intense OCD by John Grayson, that goes over all the different OCD subtypes and really helps just give an overall good understanding of what OCD is.
Yeah. A Family Guide to Getting Over OCD by John Abramowitz is also a really good resource. Yeah.
Oh, yeah.
Oh, yeah.
And then there's the other one I mentioned.
OCD.
Abramowitz's workbook, Getting Over OCD, which is also in front of us, is a great one for adults. And, I think that the biggest thing is making sure that you're finding a book or workbook that's really rooted in evidence-based interventions, because it's a slippery slope out there, right? But the internet and text of like what you can come into counter with, and you can get really stuck of like, am I doing what's right? So make sure you're thoughtful about that. So another question that we have is, my daughter's recently been diagnosed with OCD, but it looks a little bit more like anxiety to me. How can I support her as she develops skills?
Yeah.
It's a great question. And I think it's very similar to what we have been talking about, right? And allowing your child to experience that anxiety and build confidence in her ability to experience that anxiety, right? Something I often talk a lot about with parents is like, do exposures with your child, right? Whether that is your child's anxiety, like child's exposure, or your own exposure of things that maybe you're anxious about, right? And do it together to show that confidence, to build that within themselves.
Yeah, great question.
I love the next question. My child started this when they were younger. Whenever we would give him a kiss, they would tap it and say, put a top on it. He usually has to do it however many times we kissed him. I'm not sure if it's a ritual or compulsion or just a cute ritual that he developed. And do we need to worry about stopping it?
I also love this question because oftentimes we don't know, especially when they're super young, right? Is this a compulsion, or is like this just something that they like to do that they find enjoyable? And usually the way that we determine that is, would it cause them distress not to do it, right? So would your child be in distress if we didn't put a top on it? So adorable. And if so, then it is probably kind of feeding that anxiety cycle, right? Our goal is to get them to a place where, especially as they get older, they can put themselves to bed at night, or you're kind of looking at the bigger picture. Is this feeding the symptom, or is that compulsion growing? Like, is it harder for this kid to, like, are they talking about doing this with you earlier at night, or are they having to do it multiple times? Is it growing into something more than just the quick 2-second thing that they were initially doing? All of that is kind of evidence that we're looking at something bigger that probably needs to be treated.
Yeah, and I want to think a lot too with this of like, is this the only place we see it? Because all kids have rituals, all people have behaviors. My husband checks our doors every night before we go to bed, which is great. I don't have to worry about it. But he checks them once, right? He checks them once. It's like his nighttime ritual before he goes to bed, is he gets his water every single night and does a little round at the house. And it probably would cause him a little bit of distress if he didn't. But it truly, for him, it's not. He's doing it once and walking away. It's not disruptive. It's just a part of his nighttime routine that's very kind of standard and mundane. And there's not anxiety for him attached. There's not urgency attached. And so I want to look at the way bigger picture of like, is this the only thing they do? Okay, do we need to be preoccupied with it? Versus, is this one of many rituals? And do we see anxiety in other areas? And is bedtime kind of starting to rise anxiety and distress overall? So all great questions. Next one is, what can I do if my child with severe anxiety doesn't want to go to therapy and their issues are really starting to negatively affect the whole family? We hear and talk about this all the time.
Yeah. If your kid is refusing, that's really hard one, because there has to be some form of motivation to do exposure work successfully. That being said, there's still answers for them to be able to have effective treatment. I would usually encourage you to start with SPACE protocol. This is supportive parenting and treatment form where the parents start reducing their accommodating behaviors in order to kind of coincidentally have the kid do exposures without really knowing that they're doing exposures, and it's very effective. And when we see that this kid starts building momentum, I actually have done this with quite a few outpatients that weren't ready. I started SPACE with the parents. The kids started to see, oh my goodness, I actually am doing better, or I actually can do some of these things that I didn't think I'd be able to. They get more buy-in just by the parents' change in behavior. And so then I started outpatient work with the kiddos. And so my main recommendation would be for parents to start SPACE, and that can alone build readiness for your kid to do some individualized work.
Yeah. The only thing I would add to that is One thing I hear all the time that I just want to caution you and to be thoughtful of is that when your child is under 18, you get to control, like putting them in therapy and kind of pushing them to do it, even if they don't want to. As soon as your child is an adult, you don't have any control over that. They don't even have to sign an ROI. You may not have any ability to talk or learn about what they're doing and what their therapy intervention is. So even though they may not want to go when they're a minor, you still get to make decisions for them. And so, you have that option to kind of push them to do it. However, make sure you're with the right provider. And when we say the right provider, we mean someone who has background training and specialization in the treatment of anxiety disorders and OCD and has extensive training and supervision in cognitive behavioral therapy. Because what we don't want to do is push somebody who's resistant into therapy that isn't the right therapy. And then it just reconfirms all their biases and their negative beliefs and keeps them more stuck.
Yeah, absolutely.
Next question is, can aggression be a part of OCD?
You're not gonna like my answer, but it depends. I feel like a lot of questions when it comes to OCD and anxiety are around it depends, right? It depends on the circumstance. It could be if you're noticing the child really getting very angry, maybe you're reducing those accommodations, you're not giving into the child's anxiety, you might see some aggression. Things to look out for is that aggression becoming very disruptive, right? What level of that aggression is it? That's when maybe you have to look into more things.
Yeah, and also if there are compulsions involved or like intrusive thoughts, especially, I can see aggression in the younger kiddos often where these intrusive thoughts are so disruptive and bothering them so much that they can get so angry and they don't know how to cope with it. So they might be hitting things. They might be pushing a desk over because of how distressing those thoughts are. But again, that's just another indicator that they need coping skills desperately in order to learn how to tolerate that distress in a more effective way.
Yeah, I want us to think about a couple things here. Aggression can be much like depression, where OCD can be, or anxiety can be primary. And then because it's been untreated, they start to get really frustrated, upset about their OCD and their intrusive thoughts. And we see kind of their frustration towards their anxiety and OCD come out as aggression or anger. We can also see this with depression, right? We can see where patients start to become depressed because of their anxiety, because of their severity of their OCD or their symptoms. What's important to note is that most of the time, if the anger or depression is secondary, when we treat that primary diagnosis of OCD or anxiety, we should see those secondary things go away. However, if somebody is dealing with secondary depression, but they're becoming suicidal, right, or safety is at risk, now the depression becomes the primary treatment focus, even if OCD might be more primary. Why? Because safety takes priority. And so it's the same with aggression, right? As Victoria's saying, like if that aggression is really severe, it's disrupting the family, it's like we can't live in this household, we will need to address that first, even if it's secondary. So both can be true. What I will say, though, that I want to note is aggressive behavior itself is not a symptom of OCD. So somebody being aggressive, they might be aggressive because they're distressed from their OCD symptoms, but the aggression is not OCD. When we get this question similarly a lot with adults who self-harm, where people will say, can self-harm be OCD? And it's like, the self-harm behavior itself is not a symptom of OCD. You are not self-harming as an OCD ritual. Although you may be self-harming due to your OCD distress, that is now a secondary issue we need to worry about and work on and address. And so you can still do great behavioral interventions for aggression. CBT is still an amazing intervention for aggression. So your same provider may be able to treat it, but the aggression itself, I don't want you as a parent to dismiss it or to say, oh, that's a part of their OCD. No, like it is still important that in your household you have rules and you have norms and that you expect those certain have those same behavioral expectations for your child with OCD that you do for your children without OCD if you have other children without OCD. So just important to differentiate and to make sure we're not labeling everything as anxiety or an OCD if our child has it, because again, then they're not going to get better because we're not going to be treating them as separate issues, even though that's what they are and that's how they're presenting. Is there a specific age that OCD occurs or is often diagnosed?
Yeah, we can, if I had gone to the right provider myself, I probably would have gotten a diagnosis at age 3. I was doing a lot of compulsions around that time. We didn't know what it was, but OCD really, we see diagnoses tend to kind of peak around times where big life changes happen, right? So When moving from schools, for example, moving out of the home into college, we see a lot of people get diagnosed around that 18 to 21 age range. I think we also see quite a few diagnoses around that 8 to 12 age range, and just any big life transition, but you can see it in as young as 3-year-olds and receive a diagnosis that early. I will say, additionally, people are often diagnosed much later than the onset of symptoms right now, which is unfortunate. We just don't have enough clinicians trained on how to recognize and acknowledge OCD. And so a lot of research shows that it still takes 17 years from the onset of symptoms to receive an appropriate diagnosis for OCD.
Great question that's coming up, and we'll do it twofold because I want to attack onto it, of course, but how do we encourage someone to do ERP and exposure work when they're really resistant to the thought of exposures?
It's a great question.
Get it all the time.
Motivation is one of probably the hardest things to develop, especially when the thing is so fearful, right? The thing's scary. You're asking someone to do something that their brain is telling them is the most dangerous thing alive, right? So where we really want to start is identifying the reason why, right? Why are we doing this hard thing? What are we aiming to get back in our life? So a lot of times we talk about kind of the greater good statements and what have we lost to OCD, right? And what are we fighting for? How can we use that motivation of what we're fighting for to do the hard thing?
Yeah, we work in a residential facility for OCD at OCD Institute of Texas and for adults. And the way I approach it is I often won't take no for an answer. But what I mean by that is there's always an exposure that they can do, right? So if the patient is unwilling to open their car door because of contamination related fears, okay, could we go stand by the car? Okay, maybe they say no to that. And I'm still brainstorming with them is there an exposure that we can do that gets them 1% ahead of where they were yesterday? And so oftentimes I would say to clinicians involves a lot of creativity, a lot of even just collaborating with your peers that treat OCD as well, of like, what's an exposure that we can do here that maybe they would be more willing to do to just get them into that door.
Mm-hmm.
Yeah, and I'll say a couple things. Dr. Kevin Chapman just did a really great I don't know, it's not called a reel, but a post or story, whatever. I'm not good with social media.
It wasn't real, but
on Instagram about this, and I loved it because the question he got asked was something along the lines of like, can exposures backfire, and like, is that common, and do we see that happening? And how he really explained it is that the research, which is what we go off empirically supported research, right, would say no. Like if an exposure, but that also the caveat is that if it's done correctly, right? Flooding, which is like throwing someone in their highest level exposure when they're not prepared and not willing, absolutely can backfire. And that actually is not what we call exposure work. That doesn't fit in the exposure realm. And so exposures themselves are extremely successful. And when you think about exposures, I like to spend a lot of time in the education phase really breaking those myths and misconceptions of what people think an exposure is going to be and what talking about why they're afraid of it, but also empowering them to understand they've been doing exposures their whole life, right? How do you think you learned to walk? How do you think you learned to ride a bike? How do you think you learned to drive a car? Like you were anxious, you were scared, and you approached hard things and you did it slowly. And what happened? It created an opportunity for you to build confidence, for you to feel proud of yourself, and for you to learn a new skill. And also teach your brain something different than what your brain is telling you. Your brain might be telling you, I can't do this thing. And after exposure work, it's, oh, I can do that, right? And I'm actually really good at that. Or that was actually kind of fun, right? It's about creating new learning opportunities and creating those new loops in our brain. And that's exactly what exposures can and should do. But I think a big mistake a lot of clinicians make, number one, is they're not really trained in exposure work. They've read a book or they've listened to a podcast, which is great, but they're really not equipped to be doing exposure work with patients. And so they are doing it incorrectly. They're pushing them to do too much. They're not focusing on response prevention. They're not spending enough time helping the patient understand what it should look like. And it can backfire in those cases, but when done correctly, it should not. It's also really important with clinicians. I think there is this like belief from parents, and of course I get it from parents. It's like, hurry up and get my kid well. But there's this pressure sometimes to hurry up and get into exposures and to hurry up and do the behavioral work that's going to make a difference. But I actually want to encourage people to slow down, because I would much rather you slow down and get buy-in, make sure the patient and the family really understand why you're doing the exposures, what the exposures you're doing are, and what the purpose of them is, before you ask them to start doing that really hard thing. We want to take time with that and build it. But exposures create new learning, and it's really an amazing thing. And again, whether you have OCD or anxiety or not, you've done many in your life, and you probably do them every day.
Yeah, I also just think, kind of echoing what you said, if there's a provider that's trying to do exposure work that should not be doing exposure work, it is so detrimental to that patient, because that sends a message to the patient and to the family that maybe ERP isn't for them. And that is just so not the case 99% of the time, right? It's more so that they just didn't do ERP in an effective way. But I hate when it's kind of just like someone going to a therapist and it not being a good fit and then saying therapy isn't for me. No, like, it's about rapport building and making sure that you have a good fit, just like you are doing really good ethical ERP.
And remembering that, like, the same exposure can be done well or terribly.
Right?
So it's not always the exposure itself. It's often the approach and the way you do it. I always like to give this example, but when my daughter Olivia was about 2.5, she went to visit. We were visiting my sister, and my nephew Brody had this electronic dinosaur with these like light up eyes that are honestly a little creepy. And she was terrified of it, right? So the first time she's like, "Oh, I'm so scared. No, hide dinosaur." And like me being a parent, right? I jumped into parent mode. I take the dinosaur. I'm like, "Matt, my husband, I'm like, hide the dinosaur." And so he like goes and throws it on a shelf. And I was like, she's like, "I still see tail. I'm so scared." And I was like, "Matt, like, really? You couldn't even hide it?" And he's like, "Oh my gosh." So he's like hiding it, right? And of course, 2 seconds later, I'm like, what did I just do, right? I just created and enabled this belief that you should be afraid of that dinosaur, that it's dangerous. So of course, if y'all know me, like, we're pulling that dinosaur out, right? But I always tell people, I think people envision that exposure therapy means I waited till bedtime, I put her in her crib, and I shoved this dinosaur in her crib and just said, "Good luck." No, I did not do that, right? That would actually be traumatizing to the child. That would not be helpful. And she would probably actually be more afraid of the dinosaur in the morning than helpful. So what did I actually do? I pulled the dinosaur out. I started playing with it, right? I started modeling that I'm not afraid of this thing. Oh, look at it. Wow, I love its noises. Look how cool it is. And slowly she warmed up and she came over. I did make it clear to her that, like, Olivia, you are going to touch the dinosaur and we're not leaving, right? So I didn't give her a choice to avoid it. But a little bit in her own time, but like, we were in a confined space, and eventually she comes over, she starts playing, and within a few seconds, she's like, "That dinosaur's silly. It has pink lipstick," right? And it's like, okay, now this is working, right? We can like notice the cute things about it. But the next day, when she woke up and saw this dinosaur, she was still scared. She wasn't as scared as day one, but her first reaction was to look at me and be like, "No dinosaur?" And I'm like, "No, yes, dinosaur. Like, we are playing with this dinosaur today." And we did the same thing. And by the third day, she's carrying the dinosaur around and loves it and isn't afraid of it, right? But exposure work is about being done. Like, I have 3 rules for exposures. Exposure should never be a surprise, right? We're very clear. We tell people what we're going to want them to do. It's like sleep training with a child, right? But anything, you don't just do it. You explain it. You talk about it. You kind of lay the groundwork for it so people are prepared. We don't just surprise exposures. We don't purposely throw stuff at people or trigger them. Number 2, we do it together, right? The first exposures, this is why it's so important you're with a clinician. And if you can, we really do want you to be in person, at least at the beginning, because it is so important that you show that patient, we're in this together, right? I'm doing this with you. This is collaborative. Like, I'm touching the dinosaur, you're touching the dinosaur, not, "Oh, this is creepy, good luck," right? Like, no one's going to want to do it. And then the last thing is that we should never ask a patient to do something we wouldn't be willing to do. So exposures are not meant to be fear factor. It's not, let's see how gross and disgusting and, crazy we can get. It's, I want us to do things that make sense, that relate back to life, and something I'd be willing to do. So exposures have to be done correctly.
Absolutely.
What are some good coping skills that are taught for patients with OCD?
Good coping skills. I like, my favorite is probably ride the wave. Ride the wave of emotions. Just allow yourself to really embrace it, right? So whether that's anxiety, whether that's fear, whether that's discomfort, right? And then allow it to come back down on its own without doing anything about it.
Yeah, I like just reminding them that if you're feeling discomfort, it might mean you're doing a really good exposure, right? So often I think we view discomfort as, I'm doing something wrong, especially when we don't know what ERP is or what it is to lean into an exposure. And so reminding them that, oh yeah, if this feels uncomfortable, we're probably doing some good exposure work around here, and celebrating that and normalizing it a little bit, because we are so used to saying, "Oh, anxiety, bad, I shouldn't feel this."
Yeah. what both of you actually did is you didn't give any coping skills, which is important. And this is actually important. And I think a lot of people think that treatment means when we're anxious, when we're doing treatment, we need like they think of a coping skill as something to reduce anxiety. But can you both talk about, or one of you talk about the importance of why we actually don't do that? We don't ask you to deep breathe or to count backwards from 10 or to do things that are going to reduce anxiety. Instead, we ask you to ride the wave and we ask you to expect that it's going to be uncomfortable, which feels opposite of a coping skill.
Yeah, no, absolutely. It's what message you're sending to your brain, right? So whenever if we get anxious and we do deep breathing to relieve that anxiety, we're sending the message to our brain that anxiety is dangerous and we can't handle these feelings and we can't tolerate it.
Yeah, and I often will have people, when I answer this question in a clinical setting, ask me, well, but like I heard that mindfulness is really good, or I heard that doing yoga is really helpful for your anxiety. And I think the way that I like to answer that, because I just feel like some people are probably thinking that as they're hearing us explain it, is yeah, in its own time, right? But also kind of going back to what's the function of that behavior. If I have a patient that's doing an exposure and they feel really anxious and they're immediately going to YouTube and watching something of mindfulness, the message they're still sending to their brain is, you can't tolerate this. You got to feel better immediately. And so it's really about knowing that like we are truly riding that wave of anxiety before we're doing something to bring immediate discomfort, which feels more like a compulsion.
Yeah, I love that. And I think it's really important to know that word you say, Callie, like the function. Like if the function is to make us feel better in that moment, it's going to reinforce the whole cycle, So it's about how do we ride that wave? How do we expect it's going to be uncomfortable and move through it? A question we got, earlier was, my child does some rituals, but they don't really seem like OCD. They seem like they're more part of my child. Like, how do we differentiate? Because kids do have rituals, and also rituals sometimes can be indicative of other things, not always OCD. So can y'all speak about that for a little bit?
Yeah, I'll speak to sometimes there's other things going on. One of the comorbid things that can happen when we didn't really talk about is someone can be diagnosed with autism or experiencing autism, right? And so there's something known as stemming behaviors with autism, where someone might be engaging in repetitive behaviors to stem or to feel better or to regulate themselves. And it's not really necessarily done to prevent something bad from happening. It's done as just a way to effectively cope for that individual. And so really, again, going back to what is the function of that behavior? Are they engaging in this repetitive behavior because they need immediate relief? Are they engaging in that repetitive behavior because they don't want something bad to happen to mom or dad, or because they don't want to get a bad grade, or because they don't want their friend to be upset with them? If the function is something along those lines, then they're doing that behavior to just get that temporary relief, and we know that it's going to come right back around. Versus if they're repeating something like a mantra at school that everyone's saying, all these like slang things. I learned what sus was. Yeah, 6-7 or sus. Like they'll literally say sus every other sentence. Yeah, suspicious. Did you
I am.
You said suspect. It's suspicious.
No, suspicious.
Like
sus.
Oh, okay, okay. I was like, well, I'm trying to hear them both of you.
So this leads me to my next question, Victoria, I want you to cover is how do we differentiate, and you can speak about it as us from clinicians, but also for parents to understand the difference between behaviors that are egosyntonic versus dystonic, and why is this important when we think about OCD?
No, absolutely. So egosyntonic is all about being in line with your values, being in line of what you truly want in your life, what you care about, while ego dystonic is completely against your values. And it's really, when it comes to OCD and compulsive behaviors, it's you're engaging in things that you don't want to be doing, you feel forced to be doing, right? So it's so important to differentiate, because that's really where the disorder piece comes in, right? Is where you feel like your child, right, whether you're looking at it from a parent perspective or a clinician perspective, is that child is doing these behaviors and they don't want to be doing them, right? They want everything in their power. They just want to stop. But they can't. They feel like they can't. Well, they actually can, but they feel like they can't, right? They feel like they have to do it.
They want to, or it helps them function, right? There's a big difference of something feeling like, oh no, this like helps me function, right? So you think about like even with some like autism, sometimes you'll see kids in the home that like they sit at the same seat, and like people like there's certain rules in the home, and it's kind of like how they function, but it's how they operate and it works versus I don't want to have to sit here, but this is the only chair I can sit in because the other ones feel contaminated, and it would be way too triggering to trigger my core fears to sit in a different seat versus no, like this is just my seat and those are y'all's seats.
Yeah,
exactly.
Yeah, or even I just think the question we often get asked is, well, but like my kid lines their stuffed animals all up in the same way, and are they liking that? Like, does it bring them joy? Is it something that they do when they play? Are they doing that because they feel like if I don't do this, something bad's going to happen on the other side of it?
Yeah, when Olivia was first, displaying some symptoms, my oldest, of anxiety and OCD as a kid, before bedtime, she would start asking all these questions, and she started asking questions about her books. She would say, like, "Did you put the books up, Mom? Are they in the right spot?" And she would say it with these tears in her eyes and with this intensity and anxiety, where I was like, "Okay, we got to do some quick ERP," and like we did it, right? But like, it was very clear that this was not like, "Oh, are my books up?" And like, I like them there. And did you put them there? It was scary and distressing, right? And you can usually tell the difference. So
you can see it in the eyes.
See in the eyes, yeah, for sure. In the voice and the trembling. So this leads into the next question. How do you differentiate between an autism, perseverance, and OCD? I 1000% think it's OCD and anxiety, but providers are saying autism. But after almost 2 years, not much is changing. And everything you say is resounding to me. So how would y'all differentiate between autism and OCD, and what does that look like?
Yeah, I mean, I would go back to, again, are they engaging in these behaviors because they feel terrified, or you see the fear in their eyes? If they don't do that, are they engaging in these behaviors because, for example, stemming behavior might happen when it's really loud outside, right? There's a lot of noise and stimulation going on. And for someone with autism, that can be very overwhelming. And so they might be repeating something over and over to self-soothe, would be the way that I would explain it. And that's really where I see the biggest differentiator.
Absolutely. And it goes to the function of the behavior, right? Like, are they doing it to self-soothe, or are they doing it to relieve some sort of anxiety?
Yeah.
And what are the behaviors? Behaviors of OCD are bizarre, and they don't always make sense, and they are related to a specific fear or intrusive thought. Where with autism, it can be more of like, this is how I need to function, right? This is how I understand the world. This is how I operate in this world that feels chaotic and loud and overwhelming to me. But the biggest thing I would say is get a true clinical assessment. When I have patients, even if I feel like I know, where it's like, oh, there could be these other things and we're trying to differentiate, let's stop trying to guess. Let's stop trying to do interventions and see if that gets us an answer. Let's go do a true, what we call, psychological assessment. And when you guys hear somebody recommend or talk about a psychological assessment, this is done by a clinical psychologist only. And if we're looking at autism, we want them to be ADOS trained. This is really important. ADOS, the ADOS is one of the most validated measures for assessing autism. And so I would want to go do, if you haven't done it, a true clinical assessment with a psychologist where they do the ADOS. And this will be, we're not talking a 1 hour session with us to see if it's OCD or anxiety. This is a multi-hour session. They're gathering information from family, often from school, but like other collateral information, and of course, assessments, multiple assessments with the child, where they will be able to come back and say, these are the diagnoses. Now, important to note, autism is one of the most common diagnoses with OCD for children, right? When we're diagnosing in that age. So it could be both, right? It doesn't have to be one or the other, but it is really important to understand, is it one or the other, or is it both, so that you can understand which behaviors are better explained by autism or by OCD, because the treatment and intervention does look different.
Right. Which behaviors need the exposure with response prevention versus, like, with autism, sometimes we're promoting stimming behaviors.
And we're engaging in just kind of these behavioral interventions that make sense. So, great question. In regard to distinguishing between anxiety and OCD, anxiety being more focused on general real life problems and OCD being more unrealistic, intrusive thoughts, what about real life fears that aren't necessarily likely? A child may be having a constant fear of someone breaking into their house at night, or maybe right now you live in Houston where the World Cup is coming and you're worried about Ebola getting brought here, right? But like, really, like, we get this all the time of, how do we differentiate between when we're like, okay, that's a little anxiety provoking versus this is OCD?
Yeah, so when we're looking at OCD, we're also looking at the compulsive behaviors, right? Is an individual engaging in behaviors that are being done to try to alleviate this anxiety, alleviate this distress? I think a big factor that I like to differentiate is the difference between type 1 and type 2 worries as well, right? Type 1 worries are maybe real life problems problem solvable, but like you can problem solve them, right? There's multiple solutions to them versus these type 2 worries where they might be a little bit hypothetical, right? Maybe there is no problem solving, which we're approaching in a very similar sense to OCD around like, we actually don't know, right? And can we be okay not knowing the answer to that?
Yeah.
I'm going to hop to one of our last questions because we're running out of time, but my 10-year-old experiences anxiety about schedules and time, worrying about being too early or late, and consistently asking for updates. What are the best ways to help him manage the anxiety without constantly feeding into the need for reassurance?
Oh, great question. Well, early on in this presentation, I would kind of rewind and make sure that you're watching the piece on supportive statements, like support equaling confidence plus validation, because we want to be providing a supportive statement without giving into that immediate relief and answering the question every time. Every time we give that kiddo the answer and we know that it's just sending them right back into the cycle, it's further exacerbating their anxiety long term. And so I might tell the kid, goodness, I understand it is really hard to not know what time it is, and I know that's causing you a lot of distress, but I also know you tolerated this really well the other day. Remember when we went to the ice cream shop and you didn't even know what time it was? I know you can do this hard thing again. So there's ways that we can do that. If it feels unbearable, like you're like, I've already tried this and it didn't work, then I would really encourage you to have a third party, a clinician that's space trained to kind of guide you through those supportive statements so that you don't feel like you're just playing this guessing game.
And that could do values-based exposures, right? We're not going to purposely have a kid show up late to a class that we know the teacher's going to reprimand them in the setting. But maybe there are some things we could be a little bit late to, or a play date that we show up 2 minutes late to because it's not a big deal, and just slowly teach them that, like, yeah, that's okay. We can tolerate this. We can't live our life totally preoccupied with the fear of being late. I'm going to do a rapid fire of a couple questions just because I can't leave questions unanswered. Trainings. The International OCD Foundation offers a BTTI, which is the Behavioral Therapy Training Institute. It's a 3-day specific OCD training that's followed up with consultations. It is the one I would recommend the most for OCD and anxiety. Of course, if you're doing any consultation, make sure it's with somebody who has extensive experience in ERP and the intervention, which doesn't just mean that they say they've treated and worked with ERP, but they were trained by a leading expert. This is really important. ACT and DBT can absolutely be helpful. In addition, we know that ACT and ERP can be a helpful intervention for OCD, but it is not shown in the research to be any more helpful than ERP alone. But many clinicians incorporate ACT. It's really, it makes a lot of sense. It's intuitive. DBT is a different intervention. DBT can definitely be helpful for borderline personality disorder, for patients who are have like impulse control issues or who are self-harming. DBT itself is not an intervention for OCD. So that would not necessarily be an intervention we would use, although we can, of course, use it for comorbidities for sure. We will do a role play. I love that idea. So maybe the next session about riding the wave. The average time period needed here. So if we're seeing somebody in our residential or our day program, which means we're really treating like the most like severe anxiety and OCD. These are patients who have tried outpatient and have failed, are not able to do homework in between sessions. They're often coming here for about 10 to 12 weeks. They're returning back home when they leave to complete full functioning. So back to school, back to life, back to career. And it's really amazing, which should kind of be the same actual trajectory for outpatient as well. If outpatient is the right level of care and someone has OCD, they should respond really effectively to ERP in as little as 10 to 12 or 16 sessions as well. Any final questions? Not questions, because that would be strange for you to ask audience questions, sorry. But final feedback, thoughts for the day, and just like how you would end the webinar when you're talking to parents, caregivers, and of course, providers treating kids with anxiety and OCD.
Yeah, I mean, this isn't easy, right? This is one of probably the hardest things that you might have to go through as a parent, a loved one, a caregiver. And there is support and there's a lot of hope, right? It's hard. It's not easy. You're going to have to do the hard thing. You're going to have to be uncomfortable, probably more often than you would like, but it is so worth it because you can see your child get freedom. You can see your whole family get that freedom that you deserve.
I would just say we have so much fun doing these webinars, especially because of the questions that are submitted that make it so interactive. And so if you feel like you didn't get as deep of a dive today as you wanted to, we're only going to go deeper. So make sure that you join our future webinars for more information. And just thank you all so much for being here.
Yeah, and I'll end with the fact that this treatment works, and none of us would be doing this work, and we certainly wouldn't be trying to educate the public in as much of a form and platform as we are right now, other than because we know it works, and it is our goal and mission to get people to the right treatment sooner. Because when you get to the right treatment, that also means you're going to have the best outcomes as quick as possible, and you can get back to your life. It is possible to live a life where you are free from anxiety and OCD. And so make sure if you're a clinician, if you're a family member, you're fighting for that. Thinking that the best we're going to get is to be more functional or that our kid or loved one will always suffer is old language. And it's language that we are going to do our best as the OCD Institute of Texas to change, to correct, and to address, because we know with appropriate treatment, freedom is possible. And it's our goal and our hope that we can get people to that sooner than later with these webinars and educational series. We'll be back, and please join us in 2 weeks for our next webinar, which will be focused on clinicians, and we'll talk all things anxiety, OCD, and the related treatment. Thank you guys for joining.
Thank you.